Interesting.
I got away from plugs a little bit, and then I started realizing if I would send a severe patient out to cornea or patients having refractive surgery, plugs were just standard of care. They were happening all the time. And I started revisiting that, and I think we want inflammation to be zero, but the answer is we want inflammation to be controlled. And I would assume if I have them on 3 months of an immunosuppressive, I probably have fairly well controlled inflammation, or I need to adjust that therapy. So MMP9 may still be positive. It's not a gradient scale. It's on or off. I may
Yeah.
have improved that number, but I can move forward.
Yeah.
Yeah, that's kind of what we felt too. And I mean, in my mind, it made sense, right? You don't want to keep inflammation on the cornea, and I think we're also victims of our own just trying to always do better mentality.
Hello and welcome to the Chris Wolfe podcast on iCode Media. Today I had a great conversation with my good friends, Dr. Shane Kannarr and Dr. Aaron Werner. And we talked about Lacrifill and how it is similar and yet dissimilar to our classic punctal occlusion, what it might provide our patients in addition to what normal punctal occlusion. We talked about the pivotal study. We talked about eye pain. We talked about epiphora. We talked about risk for other changes and challenges and how to minimize those in our practice, but mostly really thinking through what this can do to help our patients, and primarily thinking through where this is going to fit within our protocols individually so that we can help our patients. I hope you enjoy this conversation. As always, be sure to subscribe to the podcast, write a review, share it with your friends, and support those who support us. The most common questions I get include, what ophthalmological codes or evaluation and management codes should I use? What ICD-10 codes do I need to bill with this CPT code? What CPT codes can be billed together and what can't? And my favorite, how do I manage a patient who has diabetes who comes in for a quote-unquote routine eye exam? These questions really highlight the confusion and uncertainty that serves as a daunting hurdle for providers, makes it more challenging for them to care for their patients and provide those patients with the best opportunity for a lifetime of ocular health and clear vision. That's why we built iCode Education for this specific purpose. Our mission is to provide optometrists with resources to help you understand disease states, revenue cycles, and billing and coding so that you can put that on autopilot and truly care for your patients. Check out eyecodeeducation.com. That's EYECODE education.com. We've developed a premier billing and coding bundle that includes all of our billing and coding resources in one place. We also have a 10% discount code just for listeners of this podcast. Enter the coupon code EYECODEMEDIA22 at checkout. We'd love to work with you. Check out eyecodeeducation.com. Hello, dedicated optometrists. Are you looking for a way to support your patient's vision and overall eye health? Let me introduce you to Vision Edge Pro, a visual performance supplement that stands out in our profession. Vision Edge Pro contains a balanced blend of mesozeaxanthine, lutein, and zeaxanthine in a 10-10-2 ratio. This combination has been scientifically shown to increase macular pigment density, which enhances visual performance, including contrast sensitivity and vision in glare situations. Additionally, Vision Edge Pro provides 300 milligrams of DHA and EPA, fulfilling the daily requirements for omega-3s as recognized by the leading health organizations. This ensures your patients receive the essential nutrients their eyes need for optimal health. Whether it's for everyday screen use, night driving, or enjoying the outdoors, Vision Edge Pro supports your patients in seeing their best. Recommend Vision Edge Pro for your patients today and help them achieve clearer, healthier vision. Contact your local MacuHealth representative for more details. Vision Edge Pro, because your patients deserve the best in eye health. Go to MacuHealth.com and use the coupon code podcast2024 at checkout for special discounts. Well, so we, every time we start off with the countdown timer, it's sort of like our good discussion goes sideways. And just for the listening audience, Aaron and I always will do an introduction typically after, but we were just talking about, Shane being a plumber and having to kind of fill in as a plumber. He's not a plumber. He's an optometrist. But, we were lamenting for the listeners who are also lamenting with us. We've seen a lot of things related to tariffs and related to fee stagnation. And so we were lamenting about a lot of that, and then we hit start, and then everything gets erased. So, Aaron, thanks for coming on and doing this. Shane, again, as always, thanks for coming on and doing this. You know, I have a lot of questions swirling around in my mind about where Lacrifill is going to fit into my clinical protocol, and that's what we wanted to sort of have an open conversation with the three of us, and then so our audience can kind of share in that, to sort of go through the processes, the mental processes that we're going through, to say, like, this is not going to be an episode where you're going to say, we use this for every single thing. I don't think that's what you're going to hear. I don't know exactly what you're going to hear, but I don't think that's what you're going to hear.
Nope.
What you're going to hear is three clinicians who are faced with a new piece of technology that is somewhat similar to an older piece of technology, but exactly the same when you think about billing codes, which makes us less likely to think about them as being different. It forces us to think about them in being similar in ways they may not be similar. And so that's really what Aaron and I and Shane wanted to have a conversation about today. So Aaron, let's do this. Let's take a step back. Aaron, why don't you give us a little bit of an overview of what Lacrifill is? You've already dived a little bit into this on your podcast, so give me kind of a high-level overview of Lacrifill for those of the listeners who haven't heard of it, who haven't used it, and who are thinking about it.
Yep, absolutely. So Lacrifill, the way I describe Lacrifill to patients, I'll describe it here, is that it's a new novel approach to blocking the puncture, the drains from your eyelids, so that the tears that we make, we stay in the eye instead of it being a solid product like the plugs we've had before. It's a gel, and so that gel, in theory, and we can talk about this, is going to be a better block, a better trap to keep the tears in place. And additionally, it is made with hyaluronic acid, which is shown to have additional benefits to the tear film and help with the cornea. So that's how I explain it to patients. So it's not your grandpa's, or in my case, it's not my dad's punctal occlusion. It's a new novel approach to trying to keep your tears in your eyes.
Yeah, so that's, again, that's, yeah, so I think any points there? That's how I would explain it. That's how I explain it to patients, Aaron. Shane, any other kind of other nuances or other descriptors or a way that you think about this that might be different?
Well, no, I think as far as explaining it to patients, it's just what Aaron said. I kind of add the caveat, we know over the next 6 months that HA is going to leach back into your tear film, so we know that we're getting kind of this sustained dosing. I do think there's some variability in how much dose, and it's not maybe that refined, at least not at this point in time, but that really resonates with patients, as this is a product that's going to continue to make an appearance in their tears.
Well, yeah, and I think that's the point that to me seems the most different about this, right? So like obviously a punctal plug is simply, occluding your own natural tears, but with hyaluronic acid, you're basically allowing it to elute back into the tears as it dissolves over time. And there's been a number of just artificial tears over the years that have utilized that in their ingredients. So yeah, that's the question that I'm wondering is like, I think I put it in my first patient probably, what is this, April, probably 3 months ago. And so I don't know that I've got a ton of time to be able to say what the long impact is going to be different than a punctal plug. But Shane, you may have been using it a little bit before, but can you refer back to the data, or have you had enough clinical experience to know now that what you're going to see?
Yeah, I think you're going to definitely see a peak and valley. So you're going to have similar improvement, maybe initially, but I think that 3 and 6 month improvements where you definitely see some change. To rephrase your question, what are some things we think about being problematic with the punctal plug now? There can be patient comfort, right? So you have a low tear film, poor lubrication, and in many cases you have the end of that plug constantly irritating and rubbing. I think there's some hygiene issues that exist. Many of these patients have just kind of this debris-laden tear film around Kansas, Nebraska, lots of allergies, so you get a lot of debris that kind of builds up along that margin, especially right at the puncture around the end of that that plug. And I think there's overall, we could all have discussion. If you talk about a evaporative or inflammatory dry eye disease, I always think of that Venn diagram. But in my mind, they say about 30% is combined. I'm more likely to say 70% is combined. And if I'm treating inflammatory eye disease,
I'd agree.
I still want to address evaporative, and it's really hard to get patients to put another drop on. And so that's the time I would move to a plug to try to make the basal tearing better. And this is a way to maybe take that next step forward.
Yeah. Yeah, I mean, I think so. So as I look at the data, so there's the pivotal study that they publish. I think the data just shows that 6-month duration, both in terms of the improvement in Schirmer's is significantly better in Lacrifill versus a kind of form fit hydrogel plug. I'll use the generic name of that.
Yep.
It's better at all points, right? So month 1, month 3, month 6. And then what's interesting is if you look at that data, so this is just the pivotal study data. We'll link to the show notes today to kind of allow you to see where that's referenced. But the other thing is fluorescein staining is the one that really has me kind of interested, and I think that's more about the eluting of the hyaluronic acid over time, where fluorescein staining with the Lacrifill versus a form-fitted plug is essentially the same from month 1 to month 3, which is why I'm not seeing much different yet clinically in my patients. But then month 6, it's significantly different, and so those are kind of my thoughts about why it's different and why it may be better.
But what we found was interesting is, and maybe it was the when we were all measuring MMP9 and inflammation in the tears, right? I'll be frank, we got away from doing a lot of plugs because the idea was you don't want to keep inflammation in the eye. You want to get rid of the inflammation before you want to keep it there. So we haven't seen a ton of comparative data because, quite frankly, we slowed away from doing, I'll call it traditional plugs before, and I don't really have a good reason for it other than it kind of just became out of vogue. It felt like. But
yeah, how much do you? Okay, so this is interesting, Aaron. Though I mean, I got to interrupt because
please.
It makes me wonder, like, how much have we been influenced by pharma to think about? And I don't know the answer to this because I'm still in my mind. I think the same way you think is like positive MMP9s, positive inflammation. I'm not going to plug yet.
Yep.
But it makes me wonder. It makes me wonder how much I've been influenced by outside entities.
I don't think you've been influenced as much as we kind of maybe went too far, and I did the same thing.
Interesting.
I got away from plugs a little bit, and then I started realizing if I would send a severe patient out to cornea, or patients having refractive surgery, plugs were just standard of care. They were happening all the time, and I started revisiting that, and I think we want inflammation to be zero, but the answer is we want inflammation to be controlled. And I would assume if I have them on 3 months of an immunosuppressive, I probably have fairly well-controlled inflammation where I need to adjust that therapy.
Right.
So MMP9 may still be positive. It's not a gradient scale. It's on or off.
Yep.
I may have improved that number, but I can move forward.
Yeah.
Yeah, that's kind of what we felt too. And I mean, in my mind, it made sense, right? You don't want to keep inflammation on the cornea, and I think we're also victims of our own just trying to always do better mentality. Like, what better can I do to patients? What treatments are better? And in the last 5-10 years, there's been a number of treatments that have become more mainstream beyond just immunosuppressants, right? You've got amniotic membranes, you've got a whole slew of different drops, all sorts of different thermal treatments and whatnot. So I think that part of it just became out of vogue, one, because of the idea of keeping the inflammation on the eye, but two, just we've got so many other treatments. Can't throw everything at them.
Right.
Yeah. Well, I think that's the biggest challenge with dry eye and any provider, ophthalmologist or optometrist, is if you don't really know what you're treating, if you're just sort of like, well, we'll just try it all. Aaron, you and I have talked about this a ton. Shane, you and I have also talked about this. But if you're not targeted with your treatment, there's just, and I find so many optometrists think like this. Like Aaron, when we did our IPL workshop, it's like, well, when are you going to use this, and when are you going to use that? And people are just kind of like, I guess when I need the next thing. Yeah. So go ahead, Shane.
Oh no, I think I just had this discussion with my partners. We are seeing so much change, and even in drugs in development now that are looking at lid disease and different blepharitis, and how do we target that? Now we need to really evolve our diagnostic abilities to match up to this myriad of neurostimulators are growing, but who's that going to work for, and where does that fit? So we need to be better able to diagnose to make the appropriate treatment decision.
Yeah, totally agree. Aaron, what else? I cut you off. I'm sorry.
I don't know. I'm sure it was genius, so I can't remember what I was saying.
I'm sure it was. Well, let me give you some perspective. Okay, so to your point, though, Aaron, you were talking about inflammation and occlusion. And I just looked. That's one of the things while you were talking, I was looking at my data. So I love data, and I do about 11. So Chris Wolfe does about 1,100 refractions a year, and so I looked last year. It was about just a shade over 1,100, just a shade under. I did just a shade under 20% refraction to occlusion ratio. So what that tells me, what's surprising to me, is that I was like, okay, now the reality there is that there's a number of patients. I would probably say maybe 70% of my patients I just occlude over the winter, with a 6-month absorbable plug, and then the other 30 I have every 6 months, right? We re-occlude every 6 months, and Shane, classically use an intracanalicular plug. I don't like the ones that sit on the surface for the reasons that you had discussed, but that means, okay, so let's just say it's just a shade under 20%. I'm using them quite frequently, right? Actually, I'm using them more frequently than I would have thought until I ran that data. And so then it makes me think, well, so for these patients, at the 6 month, am I refilling? Or do I not have to fill as often? What are your thoughts about that, Shane?
So right now, my plan is to bring patients back at 6 months, and my assumption would be that I'll refill. I think part of that's going to be just based on patients' symptoms, as well as clinical signs if there's an interim visit. You bring up a really interesting point about occluding over the winter. We tend not to include quite as much over the summer, because then you just set those allergens on the eye.
Yeah, I'm with you.
So this gives me a nice mechanism to say, hey, I'm going to get you through the winter. We'll see you in October, November. We'll get you through the winter. And I think there's some real merit. And I think HA is a topic we just have to drill into more. I think we need more data we have good supportive HA with data. What we don't is, in the Lacrifill model, we need to see some more data to show us how that is working. And I inherently, I think it's going to be a real benefit over what we've been doing as far as dissolvable plugs.
Yeah.
Yep.
Yeah. What do you make of? Yeah. Go ahead, Aaron. Sorry.
No, I was just gonna say I would completely agree. And unlike you guys, I live in San Diego, where we have 360 days of allergies a year. It rains 5 days and they go away, and then it all comes back in with a vengeance. So most of our patients that are dry eye are also being treated for allergies, right? With drops and whatnot. I went back and looked at our numbers, and historically, I'm surprised, because you do significantly more plugs than we did. I think we got away from it strong. And although this year, looking at what we've done, just as a whole office, I haven't broken it down by doctor, but we're significantly ahead of pace of where we were last year. And I think part of it is the what we're seeing from the HA on Lacrifill, right? The staining, because we don't do a lot of the Schirmers or any of the other tests, right? We just I want functional. What does the cornea look like? And it's being tolerated significantly better by patients. And I'll be honest, part of it probably is a little bit of excitement of, hey, we've got something new to engage with. I think patients benefit from that.
Yeah. I agree.
Go ahead, Chris.
So let me actually, both of your opinions. I want your opinions on this. Are you so one of the kind of side effect profile of each of those when I look at that pivotal data, epiphora was slightly more likely in the Lacrifill group than the control group. But are you filling all four? Because typically with occlusion, I'm with plugs. I'm mostly using just the inferiors unless I need more oomph for some patients. I also, Aaron, I'm with you. I don't use Schirmer anymore. I usually just use tear meniscus height that we get from our
diagnostic.
Yeah, our diagnostic testing. That's been associated with. It's been kind of correlated that you can rely. They've been correlated together. So I just sort of stopped doing Schirmers. So I'm with you. That takes too much time for most patients. But I guess the question I'm having is, are you just filling all four automatically, or are you starting with two and then taking a more conservative approach like I do?
Unless they're very severe dry eye or I have recurrent erosion would be a time that I'll fill all four, where I really want to be aggressive. So much more drainage occurs from the inferior two. If you look, it's not a double benefit. You don't maximize that benefit by two because you fill the upper. So we tend to do the lowers primarily, and we see good benefit. Going back to staining, and this is just an in number of about 3, I think you'll see some patients if you use lissamine with improved lid wiper. The few we've looked at when we put this in, I think because of the lubrication in HA, and I think lid wiper is a great diagnostic approach that we often miss.
Yeah, I totally agree with you on lid wiper. I mean, you can get, and I do. I always tell people I'm lazy. I'm a lazy clinician if I let myself be, and so I have to hammer myself constantly. Okay, always stain with both fluorescein and lissamine green, and lid wiper has gotten me in the past, and that's one of the reasons that I don't make the mistake anymore. Where patients just you fixed everything looks good, cornea looks great, and the patient still has this sort of scratchy, gritty feeling. You flip the lids. I mean, you've done everything. And then you're just looking right at lid wiper and oh, okay. I made that mistake years ago. And, foolishly, I felt silly when I finally figured it out. And once we made that go away, it was, all the symptoms went away.
Yeah. And I think Lacrifill will serve as a great product.
It's really interesting. Yeah. So that could be another indicator. We're going to kind of come back to. Now, obviously, we're not pigeonholing it to that, but if you're thinking about a patient that might benefit even additionally, it's going to be pay attention to from your perspective. It's pay attention to lid wiper.
Yeah,
yeah, which is common. If you pay attention to it at all, you're going to find it a lot.
Yep. Yeah, our just exam sequencing I think has changed a little, and the minute I come in the room, I put in fluorescein for a comprehensive exam. If you'll put it in before your refraction, you'll see so much more staining, and it's to my knowledge, it's never burnt me or skewed a refraction because you put in fluorescein. So as soon as I finish that and look, I put in lissamine, talk to him a second or two about what I found. If practitioners would just start doing that, I think they would find so many more dry eye patients and really let you delve into symptom-based discussion with your patients.
You're speaking my language, Shane. I mean, the thing that I like about this is I actually do something different, but I don't really care that what what I do at the comprehensive exam is different than what you do. What I care about is the conviction and the thought that you've put into this, in knowing this is what I do, this is why I care about it. Now it opens up a bigger discussion. That's the most important part for me from a comprehensive care standpoint. It's I don't really honestly you and I can debate whether or not staining is as effective as, meibomian gland evaluation and meibomian gland secretion score. But really, to me, it's not that important if you believe and you own in what you're doing and you adhere to it every single time. So, like I said, I'm lazy if I let myself be. But I know if I see this, I have to, I can't not talk about that. So I'm going to always do this. And that helps me not be a lazy clinician.
Yeah, and I agree with you. I think that structure and we all can vary it. And I'm gonna do imaging of the lid when I bring them back for a dry eye follow-up.
Yep, I'm with you.
But we all want to get to the same endpoint. It's just making sure you don't miss things. And I think it's very easy to get so caught up in a refraction that we maybe forget the bigger picture sometimes.
Aaron, you want to comment on that at all? Man, this is like, it's so amazing because it's kind of like, Aaron, what you and I and what we've really been working toward with the comprehensive care protocol and COS. Yeah, what are your thoughts?
Yep. Well, I think that what both of you guys are saying is just, having a system, right? You have a set, repeatable approach every time to the evaluation of, in this case, dry eye disease. The more you're systematized, the more you can really evaluate what the causes are. And I think it's not just finding the causes, but it's also being able to tell the story to your patient. Because at the end of the day, we've got to sell them on the idea they have a disease. We have to sell them on whatever treatment. And quite frankly, I don't care if it's glaucoma and we're selling them on using a drop every night, or in this case, dry eye, and using a drop, or whatever treatments we recommend. And what I found with treating dry eye is very similar to what I find with treating patients with diabetes. They tend to be some of my most frustrating because they don't they don't internalize what I'm seeing. And so it's a cross between, needing to show them the imaging, which is where I think that the dyes come in so handy. And I can see it, but if I can take a picture of it and show it to them, that's one thing. And then I think it's also highlighting how underdiagnosed neurotrophic keratopathy is. I think we've got a lot more patients walking around with desensitized corneas, and we're not pushing hard because they say, well, I feel fine. And that's a huge disservice.
So without going,
totally.
I am currently involved in a non-paid study, so I think it's okay that I say this. Actually, Milton Hahn, I think, is the biggest driver in the study. It's through Tufts, but there's a group of practices across the country looking at what is the real prevalence of neurotrophic keratitis. And I can tell you, just looking at that in my practice, staggering being 90% no, staggering being that I was really underdiagnosing it, yes. And I think it's something we have to lean into. And I think the other thing about having structured exams, if you go in for your routine physical with your primary care, you're going to get a CBC, a BMP, probably at my age, triglycerides, and it's not that they think I'm bad today.
What about a prostate check? Did you leave that out?
I had a 53-year-old brother with prostate cancer, so
oh my
we
God.
will go. Yeah. So looking at that, what they're really looking at is trends over time.
Yeah.
And that's what a structured exam gives you. And that's what you were referring to, Chris, about staying in. You have to look at trends over time so you know when to intervene for your patients, like getting progressively worse or better. And I think that's so important. And coming back, that's where I think Lacrifill really gives me an opportunity to be adjunctive therapy for all these dry eye things I'm looking at.
Yep.
I think there's some new discussion and new products out concerning Demodex and the lids, and maybe it's not just looking at collarettes, but is it related to meibomian gland disease? And I think we're seeing this.
Yeah, brevis. Yep.
Yeah, and I think we're seeing all that discussion happen and move us in the right direction. And I think Lacrifill, for me, in the time that I've used it, really gives us a chance to elevate what we're already doing. So you said early in the call, you don't know that for sure where it's going to fit in the protocol, but it's going to be a part and who we're going to use it for. It's those patients that need that next level. And a lot of dry eye therapies, how many times can you do lid scrubs in a day? How many times can you put in drops in a day? And so this is a way for us to control it. This is a procedure. It's a way we can get paid because it's already approved to be paid, and it takes the onus off the patient to do it.
I would also say that the eluting aspect of I'm using that term. I haven't seen that term on any of their data, but that's my suspicion is that the eluting aspect of the HA is the additional improvement. And so where I would see it even is, what I might have been like identifying as signs of inflammation, i.e. staining of the cornea inferiorly, which could also indicate neurotrophic keratitis, to your point, Shane, and your point, Aaron, but also could just indicate that bottom portion of the cornea is just more prone to dehydration, especially with incomplete blinks and exposure. Well, this is an added, this can be an added benefit. If I'm already going to occlude, why not provide this added benefit where I may be misunderstanding? Obviously there's probably some inflammation going on, but when I would say, well, I'm not yet going to occlude until we have inflammation controlled, there may be, this could kind of, maybe occlusion becomes a little bit earlier in my mind. So I'll throw this out to you. In terms of my treatment paradigm, Shane, I don't think I'm as nuanced or as sniper-esque as you are, but generally my assumption is as yours is that 70% of patients are evaporative, and so typically I'll start with the meibomian glands as our primary treatment. And once we've treated that plus treated inflammation, if our tear volume is still low and symptoms are significant enough, or I see other signs, then I'll use a plug. That's why I'll use occlusion. That's why I've done so many of them. But now it's almost like, why wait, right? Like, why wait even further? Why not, when I'm going to do a treatment for the meibomian glands via some sort of vectored, expression or IPL with expression or something else, right? What's prohibiting me from using HA as an occlusion? It's got me thinking a little bit more about it.
Yeah, and I also think when we handle a lot of cataract patients, and that, hey, I have that funny feeling in my eye for a month afterwards. Even if I don't have routine dry eyeness, I now have this incision that's caused some elevation. I'm wondering, hey, when I'm sending you out for a cataract surgery, I'm going to put in Lacrifill. We know there's some real benefit. Let's get you through this time and see where you're at. And that's a direction we were just discussing, and I think there's some real merit to it.
I had a conversation with Brittany about just again the nuance of this between a plug and the other, and I may be stating this wrong, but a plug really wasn't an active treatment. We were just kind of holding things in place. Where this feels more therapeutic to me, right? We're doing something that continues to provide a positive benefit beyond just stopping up something, and so that's where we've moved it a little bit earlier in our treatment paradigm. I think before it was, again, I've talked about why we weren't doing it, but it feels like I'm actively treating now as opposed to passively, right? Just trying to hold on to what we have.
So there's a couple other things that are kind of on my list of things I need to work through that I want your help working through. The first one is, and really I've worked through it. So the cannula that I always use for irrigation has always been really small. So I will do irrigation. So we're not talking Lacrifill now. I'm just saying, okay, my experience doing irrigation is the typical cannulas that we purchase in school are way too big for most patients to do irrigation. You're having to dilate the heck out of them, and it's not very comfortable. So I think, Shane, I use don't quote me, although you can quote me because it's on the podcast. I think I use a 28 gauge irrigator, like a 28 gauge cannula when I'm irrigating. And I have to go back and look at, I've got a stainless steel that I autoclave. So whenever I irrigate, that's what I use. And that's what I've been using with Lacrifill as well. So my procedure has been, we'll attach that to the Lacrifill syringe, and then I'll use that. And then what I'll do is I'll rinse, I'll flush that because I don't use a disposable. Then I'll flush that cannula with just pure saline, and then I'll autoclave it. So that's probably too much work for most people because most people will just purchase a disposable. But I have not been doing that. But I think there's a lot of people that are a little. If I would tell you, I would be more apprehensive with it if I hadn't had a lot of experience with dilation, irrigation, and using that small of a cannula.
CooperVision and the AOA have joined forces in a groundbreaking initiative to transform how optometrists treat children with myopia. The Myopia Collective aims to unite our profession and its allies to challenge the status quo and elevate the standard of care for children with myopia. Everyone is invited to become a member of the collective. By joining, you pledge to act in slowing childhood myopia progression. Membership includes regular updates and information about the collective's efforts, access to educational opportunities and resources, and insights from the ambassador optometrists who advocate for community policy and changes supporting the collective's mission. Click the link in the show notes to join the collective today.
What are your thoughts?
And I agree with you entirely. And I think my first couple of years out, I hated irrigation because the size of the cannula was so large. I started in the exact same way you are. I've started buying disposable the last 2 months. The cost is inconsequential. I would say that probably cost me more in staff time for autoclaving than it does to just dispose of the cannula. You're going to
have to send me that. Send me the link for those cannulas. I'll also put it in the show notes.
I will.
Yeah. Thanks.
You should not cause the patient physical pain routinely because you're trying to insert the cannula. So that's
another one. That's the second thing I wanted to get to. So go ahead and tell me why that is. So I have some suspicion of why that might occur because I'll tell you, it was seen in the data. So it was seen in the data. It was also just, anecdotally, as we've talked to some of our colleagues, Aaron and I don't know if you've seen this, Shane, but some people have had that experience where the patient has a little bit of pain. So that's kind of segueing into the next thing, the only other second thing I wanted to talk about. Why do you think that is?
It's a great proper positioning, proper angle of approach. I think that is 95% of it. I do about half of mine behind a slit lamp when my main scribe is with me, and I'll actually have her push so I can hold that in a steady position and you don't get movement. Because I do think movement is a real other driver for pain, right? If you're moving back and forth. Otherwise, I use loops because it just frees up a hand for me to maintain that focus. So angle of approach, and then once you've inserted the cannula, holding your hand perfectly steady so you don't get movement. Those are my two thoughts. What about you guys?
My thought was that most patients just haven't had this type of procedure, right? It's most optometrists, if they're not routinely irrigating, haven't done this type of procedure. So just the newness of the sensation sometimes can be reported as pain, just because it's different than what I felt before.
Yeah, I mean, my sense is exactly as both of yours is that, if I think it's more about approach. I think it's a different approach, right? With punctal plug, you're sort of, getting beyond that sphincter muscle, and then once you get beyond the sphincter muscle, it sort of is going to maintain its shape. I think you're right, Shane. I think if you don't kind of really pay close attention, or maybe not close attention, but pay attention to the anatomy, as you get into that puncta, some patients, as they'll almost like that vertical canaliculus before it kind of bends in toward the nose into the common canaliculus. In some patients, it will divert temporally first, and you really have to pull laterally on that lid to get it to be straight. And some are straight down, and some are almost angled in there. And I think that's been my experience, is that I agree. When I approach it like I would approach irrigation, I haven't had any pain so far, but it's kind of on the back of my mind that pain may be something that a patient reports. You haven't had any of that, either of you?
Oh, I've had sense of pressure. I think one patient that I took a wrong approach, and I think that kind of a very abnormal anatomy, and I adjusted my approach when they said, "Ooh, you can watch your patient." But I think as we talk about this, for maybe some practitioners are like, well, why do I want to mess with this? He's talking about angle. It's really do 5 and you're very comfortable.
Oh, totally.
Right?
Totally.
It's not you don't need to do 100 procedures to feel comfortable. You pick 5 staff members and do it. You're going to be in great shape. But I do think you need that to feel confident.
Yeah. And I think the words that you use when you set a patient up for this are different than when you were putting in traditional plugs, right?
How so?
And a traditional plug doesn't involve an injection, doesn't involve a syringe, right? And so from a patient standpoint, when I pull out a syringe, if they're not usually getting, irrigated, right? That means pain because the needle's going into me, right? It's a different sensation. They may taste something where they're not tasting anything before. You may get, the gel coming back out sometimes. You get it sometimes coming out of the upper cannulicula, right? Using the word, just some of the phraseology, right? That I think sometimes we inadvertently will use gets registered, and those words mean different things to patients. And so thinking about how we're positioning it, thinking about just the confidence, right? If this is the first or second time you're doing it live on a patient, they're going to sense a little bit of hesitation. So I love Shane's point of doing it on 5 staff members. One, they get the benefit and they can tell everybody how, what their experience is, but then 2, you can run through what you're doing.
Yeah. Yeah, and I think, Shane, I've had, and I know you do too, and Aaron, you do as well, we train students, right? And so, like, think about how many times we train a student, and, like, the first time they insert a plug, whether it's a, intracanalicular or one that is a silicone plug that sits on top, they've done it, but they haven't done it, they haven't gained a ton of confidence, right? They've done it enough to be safe. They've done it enough to actually do it. But like, once you've done it hundreds of times, thousands of times maybe, you really get a sense of, like, how much do I press, and do I actually need to kind of swirl and sort of tease the sphincter muscle open, and do I need to use a dilator, and so we forget how all of those little feedback things, and even how we feel and how we sense on our fingers, how important that is. And the reality is that if plugs are generally underutilized, to your point, Aaron, because people are waiting till way longer to do them, or there's a concern that, boy, it's going to take me 15 minutes to do, and I'm going to start sweating, and, all those sorts of things, like, if we never do them, it becomes much more challenging to do it, and thus all the other, potential for lack of confidence, more pain, that sort of thing.
Yeah, I will tell the story sometime when I'm presenting, when the automatic hand washers first started coming out. I couldn't always get the sink to turn on, right? I'm standing there with I'm like, what the heck? And then, you almost feel this sense of sweat and embarrassment because people are watching you and you can't get the sink on. And I was finally at the airport in Atlanta, and not only the sink, but the soap was that way. And I'm like, all right, this is going to become a health issue for me if I don't get it figured out. So I stood at that sink and did it 10 times, hands under, and found out how to do it. Never had an issue since, never felt that. But when you're just trying to do a snapshot and rush through it and it's live, you're putting a lot of pressure on yourself. So step back, take a second, get it down. As simple as that was, I could cause anxiety in myself. I just had to do it 10 times.
Yeah. So
I do wash my hands at all times, just so you know. Yeah.
You're not that guy.
Yeah, exactly.
Airports always reveal that guy.
Yep.
They really do.
But it's so funny how common that is, though. I mean, I found that with amniotic membranes when they first came out, and we had colleagues who weren't using them, and it was because the unknown factor. Right? Just do it once, watch somebody do it once, and you realize, oh, well, that's easy.
Yeah.
It's that initial fear and overcoming it. It's surprising how much I think it holds us back.
And I think it's having confidence when you talk to your patients, especially if you're putting in an amniotic lens with a ring. You're going to feel this for a few days to be better. I'm sorry, you're going to be a little uncomfortable.
Totally
but it's okay.
Right. Totally right.
And we have to think that way.
Yeah.
Well, the same thing with this, right? It might feel a little bit uncomfortable, might feel a little bit different, but you're going to be better. And if I've learned anything from my female patients, right, beauty is pain. They're not afraid of a little bit of discomfort to have a positive outcome on the end. I think if we're just trying always to make them happy, that will hold us back too, and prevent us from giving good care to them.
Yeah, agreed. All right, so sort of as we wrap this up, I what am I missing? Is there something else that you guys have thought about that I haven't thought would hold me back? Because honestly, like I feel like right now after this conversation, I'm a lot less likely to be reserved. You know, obviously we have a lot of patients that have done really well with intracanalicular plugs, and my sense is now I have a lot of patients that will do well with Lacrifill because I have, you know, sort of the ability to occlude the puncta, but also this sort of secondary action in my mind that that can help to elute some of the HA. Again, maybe that's not the best term, but that's sort of the way I'm thinking about it. So anything that I should be thinking about that you guys have thought about?
No, I'm curious to just see more about the HA stuff. I know Dave Kading had a poster, I believe at SECO, looking at a couple of patients that he had, and it's super intriguing. I think right now, at least for me in the world of dry eye, is there's a lot of solutions looking for problems, and I think it's making sure that we're matching the right solution to the right problem, not just a solution because we have it. And I mean, based upon what they did in the study, and then Dave's work and what we see anecdotally in the practice, I think there's a unique, novel approach here. It's just figuring out exactly where and how early in the process this fits with all the other tools.
It has me thinking. Yeah, sorry, Shane. Go ahead.
No, go ahead. What were you going to say?
Well, no, the comment I was going to make is like, in the world of, and I know, Shane, you're not afraid of prior auths. I'm not really afraid of them either in my practice, but they are a burden. And so, if in my mind I'm thinking about like maybe using this a little bit earlier, and can I help inflammation by keeping the tear film more stable and keeping the tear volume higher, both at the same time? Do we have to run down PAs as much? Patients, the cost of other things. Not saying that we won't have to use those other things. I mean, certainly we will. But if I use this a little bit earlier, maybe with the pulse steroid after we treat my meibomian glands, that might be an added benefit even just to our practice flow.
Yeah, we're not reinventing the wheel, right?
Yeah.
We're being on the compensation side, which you're the expert in, but this is a tried and true way to be paid for it. And I think, I think the more burden you put on the patients to do the therapy,
totally,
the harder it is, and this removes them from that burden. And then I'm really thinking this is of a way to take some of those tried and true approaches that I have and just make them better. This is an adjunctive therapy. It elevates the outcomes I get from many of the other things I already do.
Yeah. Amen. All right, fellas. Well, I think that was that helped me a ton. Any other parting words of wisdom?
No, I love this discussion. I think it's not a one and done, right? We're on a journey. I'm curious to see where you end up, where the rest of us kind of end up as we go through, and continue refining and building, as you like to call them, Chris, the pillars, right? So that we know what to do, because as soon as I'm convinced more and more, the more we systematize what we're doing in the practice, the better care we give, the more efficient care we give, the better we can integrate the rest of our team in that care, because it shouldn't be on us to do all the heavy lifting. It should be on us to really direct what needs to happen for the proper outcome.
Yeah, it's great. Thanks, fellas, for being on. It's great. Awesome discussion.
Thanks, guys. Always enjoyed it.